Good morning, Leah. How are you?
Good. How are you doing, Kristen?
Good, thank you. Thanks so much for being here today.
Yeah, no problem. Happy to do it. Always happy to speak on behalf of PSI and the options that we have to help people. Can you let me know? I should have asked this before, but
Yeah.
just a little bit more about who you expect the attendees to be, just so I can, if I add in a couple other like tidbits about what it might be useful for.
Yeah, sure. So some of them are going to be coming, a lot of them will be coming from Northern Arizona,
Oh, great.
but really statewide. So our
Mhm.
organization covers statewide. We have the Northern or Northern affiliate who deals with issues up north. Um, they're all going to be folks who are really interested in advocacy, interested in
Oh, okay.
change, have participated in advocacy. This has traditionally been sort of a, a forum where we sort of discuss hot topics,
Mhm.
and then do what we can to sort of help make some change or make some progress in that area. And
Excellent.
I think this is, a lot of times we spend a lot of time sometimes talking about our SMI population, right? The seriously mentally ill.
Mhm.
We don't talk enough about perinatal mental health.
Right.
And so yeah, so I really wanted to sort of draw some more attention to this issue because it's not something we talk about very often. But again, we're so ingrained in advocacy and so ingrained within our mental health system that it needs to be on the forefront of our minds. So I've
For
experienced this
sure.
too, so I have that personal experience with it and connection. So yes, that's really our group. So some of them, most of them will all be advocates. Some will be family members, and
Mhm.
some may be peers themselves. And we
Okay.
also offer this event, or we also publicize this event in local newspapers as well.
Mhm.
So some people only attend when they see a topic that interests them.
Right.
So we might have a good, there might be some folks on here that I don't know that just came forward because of the draw, but our regulars are advocates who are working within the mental health system.
Excellent. Yeah,
I'm
just
going to
a
have,
little bit more on my background. I actually got my start right out of college as a case manager for Pima County and Maricopa County for the SMI population.
oh, you did,
Yeah,
no
I did that for
kidding.
8 years before I went back to school.
Oh, interesting. Hey,
Yeah.
Lori.
Good
I was just
morning.
talking with Leah here, Dr. Lewis. Do either one of you guys know a Taylor?
No.
Okay. I'm just going to message her and let her know we'll bring her in shortly. We will let you in shortly. So Leah, this is Lori Verdier. Lori Verdier is our chair for the Northern Arizona Parent Family Coalition.
Hello.
And also
Good
works for,
morning. Thank you for being here.
yeah, also works for Hope Incorporated. And so her and Kathy, is Kathy joining us today, Lori?
She is supposed to be joining us, and I did speak with her yesterday.
All right, perfect. So Leah, for your purposes, I usually am the ones that sort of coordinates this and puts it together. And then behind the scenes, I let Lori as the chair of the Northern Arizona Parent Family Coalition, and then Kathy as the president of NAMI Yavapai. So this event that we put on is a collaboration of both NAMI, National Alliance on Mental Illness, I'm sure you know that, as well as then the Arizona Parent Family Coalition.
Excellent. And then will I be can I share my screen with the presentation?
Absolutely. Yep. Let me give you share abilities right now. And Lori, I'm going to make you co-host. And Leah, what are you more comfortable with? Having them ask questions throughout the presentation or waiting until the conclusion of a presentation?
They can ask throughout, although I have to say I'm really bad about like checking chats and stuff. So if the moderator wants to, say, oh, there's a question here and read it, I'm happy to do it that way. Or at the end is fine too. I'm really
Perfect.
whatever works. I don't mind being interrupted.
Okay, perfect. We'll take care of watching the chat and then let you know if we see any questions come through.
Okay, great.
And I'll just unmute myself and then, or Lori, one of us will unmute herself and ask when we see a question come through.
Perfect.
So Christina, I just sent you an email. The flyer for next month says that we are meeting on not the last Monday, but the Monday before. Was that a mistake?
Oh, no.
Because there's 31 days in July.
Oh, shoot.
So when I make announcements, I was going over announcements. I thought, oh, wait a minute. I think that needs to be 31st. So,
Yep, that's a mistake.
okay. All right. Well, good to catch it now.
Darn it. Okay, yeah, thanks for catching it. And Lori, do they normally do July Mental Health Mondays?
Do we normally what?
Do Mental Health Mondays in July?
Yeah, I think so.
Okay,
But we can take a break, but we've got it all flyered and scheduled.
right, yes. I felt bad after the fact. I'm like, oh, shoot, hopefully I didn't mean to skip that month. Hello there, Kathy.
Hello, everyone.
Good morning, good morning. Kathy, this is Leah, Dr. Leigh Lewis.
Hi,
How you doing?
good. How are you?
Good.
And
Enjoying
do you
the
guys know-
weather up in northern Arizona.
Yeah.
You
But
guys
it's-
do you guys know each other?
No,
No.
So like, I don't know, Kathy, if you want to share a little bit about yourself.
Well, I'm Pierre. Spent 7 years in mental hospitals. Got loose, and since then, I was bureau chief at Access, and been very. I'm actually retired now, but doing a lot of advocacy and enjoying myself. I live up in the middle of the national forest, off the grid, by myself with the bears.
Oh, very well. No, I don't know about the bears, but that sounds idyllic otherwise.
And Kathy is always so modest. So Kathy is really one of our heroes when it comes to mental health advocacy. A lot of what we have within our mental health system now is because of Kathy and her advocacy efforts. She was also, and I asked if you guys knew each other, because Leah, what you were just sharing about the SMI population, Kathy worked in the Office of Individual and Family Affairs. She was the deputy director
Wow.
for many years, and then retired. And she jokes when she says retiring because I think she works more now than she did before, but at least she can work up in the mountains.
Yeah.
But so she's a fearless advocate, and you probably crossed paths at one point then, because she was working for Access and the
But you were with Access?
No, I mean, and this was a long time ago, Kristen. I know I said when I went back to school, but I graduated 20 years ago after being back at school. So I was working for the REBA. It was ComCare back in the day.
Oh, yeah.
Yeah, and from 1992, when I graduated from the University of Arizona, up until I went back to school in 1998. So
What did you do for ComCare?
I was a psychiatric case manager.
What site?
I was at 64th and Thomas, and then over like
That's one of the old. They did peer support there. That was one of the first
yes.
places for peer support. Yeah.
Yeah. And then Cave Creek. Well, my first place, I finished at Thomas and 64th Street, but was at Cave Creek and Greenwood. I don't know, Cave Creek and something
Way
north
up there, yeah.
for a long time.
Sure.
Mhm.
Sure.
And then I was in Green Valley because I moved back to Tucson to do my prereqs for school and worked out of that location.
Awesome.
Yeah.
So it appears that Arizona at least is going into more of a preventive mode. I mean, I'm hearing that concept a little bit more because we've been so far from it. And this seems to be one of the areas that we really can do prevention. And it seems like, the governor's office is in support of that too. Don't you think, Christina? I mean, we're starting to have that conversation.
Mm-hmm.
Yeah, I mean, yes, it's way long overdue, but I think we're definitely starting to, I think they're starting to listen. All right, and Kathy, I'll let you welcome.
Okay, so
Everyone.
welcome to Mental Health Monday. My name is Kathy Besher. I'm president of NAMI Yavapai, and we have Lori Vidier, president of NAMI. I'll let her introduce herself. Anyway, welcome everyone to Mental Health Monday. It is sponsored by the two organizations.
Yeah, I'm Lori Verdier. I chair the Northern Arizona Parent Family Coalition, which is an affiliate of the Arizona Parent Family Coalition.
Awesome. Great. Thanks, Lori. Thanks, Kathy. I'm Christina Sabetta, Executive Director of the Arizona Parent Family Coalition. And it's my pleasure to introduce Dr. Leigh Lewis today. Dr. Leigh, she was talking a little bit about her experience and how long she's been in this space and worked with a lot of the populations that we've worked with before. She's been in the field of community mental health. And she's a graduate of Bastyr University and completed a 2-year postgraduate training program in integrative women's health. She is credentialed by NAMS as a certified menopause practitioner and also Chinese reproductive medicine. How fun is that? And then with has a PSI in perinatal mood and anxiety disorders as a prescriber. And then she's also the co-chair of the PSI in Arizona chapter board. And so I've had the honor of connecting with PSI over the last 6 months. They were one of our partners for our mental health day at the Capitol. Really enjoyed getting to know them and working with them, and excited to sort of continue working with them as we go forward and see what we can do, especially when we focus more on prevention and understand how important perinatal mental health is and to our moms, dads, family members, all the above. So thank you, Dr. Leigh Lewis, for being here. And with that, I'm going to turn it over to you. I should say, just for the audience, we are going to, if you have a question, feel free to put it in chat or raise your hand. And Dr. Lewis will take questions throughout the program. So please feel free, if you're thinking of anything, plug it in the chat or raise your hand and we will make sure to pause and take questions. All right, Leah, you're up.
All right, let me just share my screen here. Okay.
What?
There we go. Is that showing okay? Hello? Oops.
You're muted, Christina. No,
Oh.
we're not seeing it. Did
It's
we?
not showing.
We need to make her co-host to have her share screen.
No, we do not. She has
Okay.
ability to share.
Okay.
There we go. And you know what, Dr. Lewis, do you mind if we just quickly go around and do introductions since there's a smaller group today? Is that all right with everyone?
Sure.
All right, so let me just quickly go around the room. Lori, Kathy, you introduced yourselves. Taylor, will you introduce yourself?
Yeah, hey, I'm Taylor Cruz. I was mentioning I recently became certified in perinatal mental health and just started my own practice a few months ago now. So this popped up on my Facebook page and I was like, yeah, I'm gonna try and attend that while my mom is here babysitting. So
Awesome.
yeah, I'm happy to meet everybody. Thank you.
Great, thanks, Taylor. Julie.
Hello, everybody. I'm Julie Pansura. I'm a field advocacy manager for Sage Therapeutics. We're a very small biotech company that is very interested in postpartum depression, perinatal mental health, and depression.
Awesome, thanks, Julie. And
Thank you.
being with Sage, I'm gonna jump over to Stephen then.
Perfect transition. Stephen Schultz, also with Sage. I appreciate the opportunity to jump on and listen in.
Awesome, thanks, Stephen. Trish, welcome, Trish. Would you like to introduce yourself?
Hi, Trisha Reiner.
Awesome. Trish, do you want to share who you're with?
Oh, I'm with Family Involvement Center.
Awesome. Thanks, Trish. Will is driving. Not sure if he can introduce himself or not.
Yeah,
There you
hi.
go.
My name's Will. I work on the Spectrum Crisis team. I'm on the NAMI board, and we're always here to help. So
Awesome. Thanks, Will. Nicole. And I know Nicole is having issues with her speaker.
Hey, this is Nicole. I'm actually coming out of Lynn's microphone right now, but I'm a social worker here at Flagstaff Medical Center. And Lynn, who is right next to me, is also a social worker here at Flagstaff Medical Center.
Awesome. Welcome. Welcome. And Nicole is oh yeah, I'm sorry. Nicole's in the room with you, Lynn?
Yes.
Okay, gotcha. All right, cool. Thanks for being here. All right, I got everyone. All right, perfect. All right, Leah, thanks for that.
And we just have someone else joining us now.
Thanks, Lori.
I am also not being able to hear Leah.
Oh, can you hear me now?
Yeah, now I can.
Okay. So thank you, Kristen, for that introduction. Again, I am the co-chair of Postpartum Support International for the Arizona chapter here in Arizona. And I just wanted to make a little clarification because people oftentimes, I think, are pretty surprised to hear that I'm a naturopathic physician and acupuncturist, and yet, was interested enough and felt passionately enough about this issue, especially in my care of women throughout my 20-year career, that I did go back and take the opportunity when I moved here from Oregon in 2015, and when I was establishing my practice here, to take the extra training for postpartum support, or through Postpartum Support International for perinatal mood and anxiety disorders. And I did go ahead too and become a prescriber. As Kristen mentioned to some of you who were on the call before, I do have a about 8-year experience in between undergrad and graduate school, when I was a psychiatric case manager for the Rebus in Maricopa County and Pima County. And so I definitely understand the place of psychiatric medications. And I truly do like to incorporate that, not just into my practice, but my education of patients and the public and other providers, because it is so important to realize that it really is a continuum of care in this space where peer support, therapy, support groups, I mean, those are all where we have the most evidence for success in working with perinatal families. And then, of course, doing the things that I like to consider, and I'm sure, y'all also are considering for your patients or family members, whoever, if we're helping to care for perinatal families, we want to ensure that mom and the non-birthing partner are getting full support to help so that they can sleep, they can eat well, they can stay hydrated, like do all the basics of health. And then, of course, if needed, help to get that person the psychiatric medicine that they require. And a lot of this really is bringing down the stigma that I know you all are working against all the time in this space, but really trying to dispel a lot of the myths around the fact that a psychiatric medication is dangerous in pregnancy, we'll talk about this in a second, but in the perinatal phase, for fertility, for pregnancy, and in postpartum and lactation, that we do have safe and effective medications for mom and for baby. And we really do need to dispel a lot of the stigma around getting care for perinatal families and the treatments that are available. And I believe at least one or two people have introduced themselves from Sage Therapeutics, and they have, I might mention that briefly down the road, but they do have some really exciting allopregnanolone derivatives that can be very effective for postpartum mood and anxiety disorders. Okay, so, oops, sorry. Oh my gosh, my mouse gets to be so sensitive here. Oh, okay. So what are PMADs? One thing I wanted to clarify a little bit, and I think any of us who've worked in a field, no matter what field that is, for 20 years, as long as PSI has been around, sometimes the name, we outgrow the name or the name outgrows us. And the P of Postpartum Support International is postpartum. We really like to consider that term as a P, incorporating perinatal. As I said, this is really looking at women and families who are trying to conceive, the pregnancy period and the postpartum period as well. And even the definition of what is postpartum is up for debate. ACOG, the American College of OBGYN, has come out and actually said that there are some percentage of women who will experience perinatal mood and anxiety disorders all the way up to 3 years postpartum. And I think when we really look at that and broaden our scope of who might be struggling with these issues, we're really going to be able to recognize and identify and refer patients more appropriately as having issues that may still be impacted by the fluctuating hormones that seem to really trigger these issues during this time frame. EM incorporates depression, bipolar, and or psychosis. And the anxiety is, the generalized anxiety disorders, panic disorder, OCD, and PTSD. And then just the idea of what a disorder is. I'm sure y'all on this call understand that a disorder is, there's a whole spectrum. And we talked about this, like I definitely want to be talking to people and referring people who are struggling with any degree of symptoms. Because I think Kathy and Kristen really picked up the idea of prevention, that if we have our antennas up to be looking for these signs and symptoms, we can get the families when they're struggling with symptoms at, say, a 1, 2, or 3 on the 1 to 10 scale instead of a 10, 11, or 12, which of course is our goal, is to be proactive and preventive. We do not want to see families in crisis. We want to be able to identify with them and refer for them prior to them getting to that crisis situation, if possible. So just some facts about perinatal mental health disorders. We know that this is oftentimes something that I think if you really think about what I'm saying here, you're going to be probably pretty surprised that PMADs are the #1 complication of pregnancy and childbirth. This is more than gestational hypertension, gestational diabetes, preeclampsia combined. So all of the things that pregnant women and providers who care for pregnant women are concerned about, PMADs is actually way more common than that. It impacts about 1 in 7 women in the United States again, that perinatal phase, and 1 in 3 women of color. And then we know that about 84% of pregnancy-related deaths are preventable, and 40% of those are caused by, or at least influenced by, PMADs and substance use disorders. The other thing to remember too is that, of course, it's a little bit of a selection bias. You showed up today, you knew what the topic was, so you're probably interested in this already. But I am oftentimes telling providers, and then even the public, is that 80% of women will experience at least one pregnancy by the time they're 40 years old. And so even if you don't think this is going to impact your life, you think about all the women who are going to have a pregnancy and might be struggling with these issues. That's a lot of people. And there's certainly, again, even if you care for men, we don't talk about it, but that's kind of going on to this right side of the slide. 1 in 10 dads or non-birthing partners are impacted by postnatal depression. So again, even if you just strictly work with men, you're still going to want to have your feelers out and your screeners available to be able to identify these non-birthing partners who might be struggling with PMADs. We also know that half of perinatal women that would meet a clinical criteria for depression do not get the treatment they need. And of course, again, in this space, I know you all are aware of the stigma that continues to really surround mental health. And I would say the other issue with this as well is that in this country in particular, we've really created such a bifurcation between mental health and physical health, where people are siloed whether it's in their system or in their training, to really think like, this is what I deal with. I don't deal with the mental health side. And, you know, you could say for the other side too, like with mental health, and I don't deal with the physical. But as a mental health provider, you know, if you have a patient comes in complaining of chest pain, you're going to make sure that person gets referred to appropriate care. If a person is, and again, you're not the one who's going to be caring for them, but it is far less common that patients in any sphere are getting referred for mental health conditions, again, in that proactive, preventive way that we really want to be helping to care for people. There's also just a lack of trained healthcare providers. A lot of, you know, I don't know about y'all on the call here who are providers, but I did not get this in school. I had an OB class, I had a women's health class, I had a gynecology class, and I had a mental health class. And it might have been like brought up like on a, you know, a handout or something like that, but we did not learn this. And so, you know, that really, and it was really about, you know, 10 years into my practice where I was like, hey, I'm working with all of these women throughout their, you know, because I really focus a lot on hormones. So seeing women who were getting pregnant or had a history of pregnancy and related to me, how much they were really struggling during the perinatal time frame, and they just didn't know who to reach out to. And even though I work with people who are trying to conceive, they would come back for baby number 2 and they're like, gosh, I had such a rough time postpartum. And I'm like, what? You know, I'm thinking to myself, like, why didn't they reach out to me? And well, it's like, it's, yes, part of it is they should reach out, but I really needed to be checking back in too with my patients in the postpartum phase. Really, and, you know, just asking the question, as so many of you know, around anything with mental health can really just help decrease that stigma and let people know that it is a safe space for them to reach out if they're having issues. So there, you know, again, that just gets to the point there that people are just unsure where to turn. And there's this largely false fear of medications. There are some medications that are 100%, and again, talking in the psychiatric realm, 100% contraindicated when trying to conceive, pregnant, or with breastfeeding. But there are a lot that can be used in this space. And with lactation in particular, don't remember if this comes up on a future slide, but we know that for some women, you know, there's such a, again, in the social sphere, this, and from some healthcare providers, there's such a pressure to breastfeed, where especially in this realm, where if we have a patient with bipolar disorder, say, for example, we want to be sure that their sleep is protected. And if that means that this birthing person decides not to breastfeed for her mental health, that is okay. Fed is best. Breast is not best. And so these are like all the, you know, the messages that we really have to be getting out to the public so that these, you know, birthing people do not feel pressured by their mom, their sister, their best friend, social media, or even OBGYNs who don't understand, doulas, midwives, lactation consultants. So we have to be the people on the other side saying, no, if you're struggling, we have many other ways for you to feed your baby. You don't have to struggle for this. We also know that untreated PMADs in the United States are very, very costly and have multi-generational consequences. When I speak about the multi-generational consequences, there's a lot of great research coming out in this space. And I'm sure that any of you who are working in social work or mental health, and especially around, again, the genetics of mental health, sure, we know that there is, in some situations, there may be genetic factors that get carried from one to the other, but we also have those epigenetic or kind of like outside genetic factors such as environment. And if we have a perinatal mental and emotional issues with either mom or dad, non-birthing partner, you are going to have issues potentially with bonding with that baby for those parents who are struggling. And that decrease or impacted bonding can then go on and have long-term consequences for when that baby, child, teen, young adult, and then potentially a parent in their future life, you can have mental and emotional issues crop up for that offspring at any time during their life cycle. Alternately, we have what's called intrauterine programming. And I find this so fascinating, but to use anxiety as an example is that when mom is carrying baby in her uterus, if she is very anxious and struggling with an untreated anxiety or mood disorder, very stressed, she's going to have elevated cortisol. That elevated cortisol gets to the uterus, can impact the baby and program baby to, again, have mental health issues as a baby, as a child, young adult, and into adulthood. So that when we say the transgenerational, we're really talking about, again, the genetics, intrauterine programming, and then just potentially the disruption in bonding and parenting that can happen. So just briefly, again, some of this I've already mentioned, but we do this in this country where there's all this attention focused on mom when she's pregnant. And then immediately when that baby comes out, everybody's focused on the baby. And, a lot of times mom will just kind of be like there in the corner doing her own thing. But, we just have that as a thing that happens in society. And we really want to try to shift the attention back to mom for at least that first year postpartum. We want to be making sure that she has follow-up. And right now, most women get a 15-minute or 20-minute, maybe 6-week postpartum checkup, but that's usually about how is mom healing from the birth? How is baby doing? How is nursing going? But if and you can imagine how much time that takes up. And then, as they're walking out the door, you sleeping okay? Oh, is your mood okay? And then they're out the door. So ACOG recommends more. They realize that this is a problem, but our medical system is not set up to give it. And that's where so many of us as ancillary providers who may be in touch with mom and the family in this perinatal timeframe, we can really be doing that work and making sure. And what we hear so many times from women is that they will be struggling and they try to go back to the gynecologist, and the gynecologist is like, hey, you had your baby, I'm done here. It's like you're past your 6-week visit, you need to go see your primary care. And primary care will say, oh, you just had a baby, you need to go back to your OB. And so she oftentimes will feel kind of like left out there. And then if you look at the non-birthing parent, they're potentially not having any interaction with the medical community. And so really just struggling there on their own. We know that lack of support for partners and families and stressors and the lack of sleep, again, that both partners can really struggle with, can really impact and exacerbate PMADs. And we know too that if one partner's struggling, that's going to really impact the other partner's risk and vice versa. And I already had mentioned about the 80% of women struggling. And we know that unintended pregnancy, again, regardless of the outcome, can really increase the risks of PMADs. Oh, so sorry. So the risk factors, we know that, and we kind of see this, and I'm oftentimes speaking to different groups about this idea of the hormonal impacts for women of their hormones on their mental health throughout their reproductive lifespan. We have, of course, anyone who works with teenagers knows that this is, not surprising, that during puberty, during PMS, and then if PMS is more significant, PMDD or perimenstrual mood, perimenstrual dysphoric disorder, sorry, spit that out, can impact a large number of patients. And then if they have that as they're younger and then they get pregnant and postpartum, they're going to be at much greater risk for having issues. Also, we know that if they've had subsequent issues with perinatal mood anxiety disorder, they can have it in a second or subsequent pregnancy. The other thing, though, is if they had a pregnancy with no increased risk or never had these symptoms before, it doesn't mean that in this setting they won't. And I will see in a future slide that a very large percentage of women get their first diagnosis of bipolar disorder during pregnancy and postpartum. So it can certainly be a new onset. And that could be maybe that they had never been diagnosed with PMDD, or their struggles as a teen were just kind of, chalked up to puberty and weren't really recognized or dealt with. Just as a side note too, I do a lot with perimenopausal issues, and we see another flare there, that you can have a new onset or recurrence of mental and emotional issues during perimenopause. And it's going to be those women who struggled at all of these other time points of hormonal flux. Endocrine issues like diabetes, hypothyroidism, hyperthyroidism, polycystic ovarian syndrome, and endometriosis. We think of those last two as being, this issue of either, just the pelvic area, and it's not going to really impact, but it really is a syndrome. And independently, PCOS and endometriosis can come with it an increased risk of anxiety, depression, and bipolar disorder. And so again, those women in the perinatal phase will be at a much heightened risk. And then
Leah, this is Lori. What is PCOS? I'm not familiar with it.
Polycystic ovarian syndrome.
Oh, okay. Thank you.
Sorry, I meant to say that when I read
I think you did, and I was trying to catch it.
Oh, sorry. Okay. And then PTSD, post-traumatic stress disorder. Please do tell me, because I am always using these abbreviations just so the slides don't get so wordy, and then I forget to sometimes say what it stands for. But I always try to counsel my patients, and then in groups like this, although it sounds like you all probably understand this already, but it is really a good teaching point for patients that I always tell them that trauma is in the eye of the beholder. I think when we talk with patients going through, especially like birth traumas, what happened to them might be totally normal and within the realm of expected during a birth. But to them, it was traumatic. What was happening in the room was traumatic. What the partner sees is traumatic. And that's what we have to pick up on, is not just like, what does the report say from the doctor who was delivering the baby, but how did the couple or anyone who was present in the room feel about that birth? And getting the birth story from both partners can be very helpful with that. And of course, and then it doesn't have to be around birth trauma, but any type of trauma pre-existing the pregnancy is important. Pregnancy and birth factors. So infertility, again, I would just put that also under the term of PTSD. I meet some women, again, just because I work in that space a lot, who, have, by the time they get pregnant, they've had 5 miscarriages or a late term miscarriage at 25 weeks. Or, you just hear all sorts of things. And that is like trauma. Even just the struggles of infertility for years can be traumatic. And then you think on the other side of that, the couples that never have a baby. And we might say, oh, well, for the couples who do have a baby, what's traumatic about that? There's a lot that goes on, and a lot of grief and a lot of disappointments that can occur over time, such that even if they have the baby on the other side, that they can really struggle with perinatal mood and anxiety disorder. And for my therapists and social workers out there, it's almost sometimes of like what they work so many years for, then they've built up in their mind to be something that's going to be great and easy and fun. And of course, the realities of having a baby day to day can be very, very difficult to adapt to. Again, since I work in the fertility space, people oftentimes say if they're going through intravenous or in vitro fertilization, they'll say, oh, I hope I have twins. I know that can be a possibility. Well, twins, triplets, that's good, sounds good on paper, but it can be a real struggle when you bring those babies home, especially if they need to, have time in the NICU and the parents are back at work and having to try to work or, juggle other children or other issues. And then they have to, obviously contend with going and visiting a baby in a NICU. Challenges with breastfeeding, again, because I would say mainly the societal pressures that this is what you have to do, or people's expectation that this is what they are going to do and how important it is for their baby, and then they can't do it, can be very triggering. And then any life stressors, which again, pregnancy, postpartum, it does not happen in a vacuum. There's stuff going on in the world. There's stuff going on in your family, with your other kids, with your partner, and all, your potentially your job, that are also going to be problematic or maybe exacerbating in this case. Oh my gosh, sorry. So I don't want to read through all of the symptoms here, but I do just kind of present this, just depending on how much you actually interact with patients or might be doing the diagnosis of patients. The diagnosis of these issues are not going to be different than what you would expect for diagnosis in any other phase of life. So with the depression, we see that in about 20% of perinatal women. Anxiety, about the same, 15 to 20%. But in a lot of cases, there's going to be some overlap. In about 60 to 70% of cases, you're going to see depression and anxiety. The baby blues, I do like to point out, that is normal. It does happen to a large majority of people, about 80%. And that's thought to be because of the physical and mental stressors of labor and delivery, the lack of sleep as you're getting your new routine set up. And then there's a dramatic hormone fluctuation that goes from being a third trimester mom to being, 24 hours postpartum. That's huge. And then of course, the reestablishment of the establishment of breastfeeding, the reestablishment of a cycle, the weaning of breastfeeding, all of these are potential timeframes where you could have a little blip in your hormones that should relatively easily even out. But this is something that is more pronounced and it lasts longer. So this is really, for the baby blues, only 2 to 14 days after the pregnancy and delivery. If it's lasting much more than that, and again, this we have to be very aware of for those of us who work in this space, because they might be getting the message from like family members or even their physician that, hey, that's just the baby blues, don't worry about it. But if they're really struggling, it could potentially be the first symptoms of a mental health condition that we're going to really want to be keeping an eye on and potentially referring for. Again, the post-traumatic stress disorder, we see in about 10% of women. And then also for that, again, the non-birthing partners too, was something we need to be checking in if we work with the family, or if we're working with the mom or the birthing person, we want to make sure that the partner is at least has someone to talk to or has some resources if they need it as well. And like I'm going to say about with PSI, we have a lot of good resources for partners. But again, the symptomology will be the same as you would expect with PTSD and other timeframes. Postpartum panic disorder and obsessive compulsive disorder can also be under the umbrella of the anxiety issues. And a lot of these things, even if I have patients who I wouldn't say that they meet the criteria for a disorder, but it is very common and I do think that part of this does come from the evolutionary process that, and anyone who's out there who has had a baby and is a mom, there is something that happens to your brain, right? You have lighter sleep. So you're just more vigilant about what's going on around you. And a lot of times these women will describe to you, they'll have these intrusive thoughts of walking down the stairs carrying the baby, and I envision myself tripping, falling, dropping the baby. or falling on the baby. Or I've even had some patients too say they're, changing the baby on a changing table, and then they're scared to turn around to get something that they need with the baby there. And they, in that split second, they envision the baby rolling off and smashing their head or something. These are, again, just like you would expect, part of it is a normal thing. It doesn't necessarily have to be like a psychosis that they're going to act on those issues or those visions that they're having or thoughts that they're having. These thoughts and visions are very scary and troublesome to them. And that's the difference, is that in postpartum psychosis, people will sometimes talk about those exact same symptoms, but with a flavor of that they actually may act on it. These moms and potentially even dads might have those symptoms, but they're not necessarily going to act on it. They know it's wrong. They would never want to do something like that to their baby, but they still have these thoughts. And again, that's probably just in as much as being a new parent is, kind of our reptilian brain there is wanting us to be on alert for any possible hazard that might come to that baby.
And Dr. Lewis, if I could just
yes.
share,
Yeah.
because that hits home for me. I know when I had my first son, dreamed of having kids, didn't have kids until older in life, dealt with depression my whole life, never really dealt with a whole lot of anxiety until I had my son. And I would breastfeed him in the loft of my house, and I would have visions of him falling down off the balcony and breaking his head open, right? And so it got very detailed for me.
Yes.
And I'm first, I tell people now, but I was scared to death to tell anyone, right? I was scared to death to ask for help because I was scared my child was going to be taken away, and I would be locked up. The police would be called, right? I was scared to tell my OBGYN. I didn't tell anybody. And so I think that it's, as a social worker and then having these experiences, this is something I was never taught. I never knew that these thoughts could actually happen to someone who's dealing with a new baby. And it's, it's just wild because people need to know that I wasn't going through psychosis.
No,
I was dealing with something very scary. And, had someone been able to talk with me about it, if I wasn't able to talk to someone and they could have been like, okay, you know what, maybe just stay in your bed. Who cares if you wake your husband up? Stay in your bed and nurse him there, right? I maybe wouldn't have had the visions of him falling from my balcony. But that's what kept me up all night. And I was so scared that I was going to kill my son, right?
Yeah.
And again, had I called anyone, I felt like the cops would have been at my doorstep and someone would have locked me up.
Well, and I hate to say this,
so I kept it quiet.
Yeah, and I hate to say this, but there is some real world examples of just that happening. If people do try to work with, say, and this is why we're so encouraging of anyone who really does work a lot, A, with women, or B, with families, and C, especially those who work with anyone, really that are going to see a lot of pregnant patients, to really get more education, because we have, one of the therapists that I sometimes present with PSI, she shares a story that is chilling about that exact thing. A mom was struggling with those exact thoughts. She tried to talk with a therapist who did not understand perinatal mood and anxiety disorders, called CPS. The police ended up coming to the house, separated mom from baby, put mom in the hospital, 72-hour hold. And when that happens, I mean, that mom, she, ended up happening, she ended up being in there longer than 72 hours, wasn't able to breastfeed because her milk had dried up by the time, and then she got put on all these medications. And it's hard to say if she was in a, with a perinatal specialist, if she would have been handled differently. But from the, again, this is a story that was related to me by the therapist, because she saw the patient after she was discharged and was able to help her. But the therapist felt pretty strongly that should not have happened to the patient, and that it was because she was, the initial therapist had overreacted. So it is very important to know. And, the thing is too, is it's like, we can't be expected to know everything about every condition, to the point where we're specializing in it, right? But hopefully, even in our 2-day training, you learn enough to know, this might be something that is either can be helped or needs to be investigated more to figure out, what's going on here. And then that's when you refer to a specialist. So thank you for sharing that, because this is a lot of this, my side things are about, patients, their experience and what has been related to me. Bipolar spectrum disorder is not a huge, not definitely as big as the anxiety and depression that we would expect. But like I said, you can have about 20% of women who have bipolar spectrum disorders have it in the perinatal period. And then 55% will relapse. And of course, if you work with patients with bipolar, you'll know that about 60% of them can be misdiagnosed several times before they get to that, either with depression or anxiety. And so they're not getting the appropriate medication or care without that correct diagnosis. Of course, any family history, this kind of goes along too with the psychosis. And again, the symptoms of the bipolar spectrum disorder and the psychosis are going to be the same as you would expect in patients of other ages and time of life. And then I always tell people, it's like, and again, I say for myself, I'm a naturopathic physician, so and I do have a history of working with bipolar patients, but I do not feel comfortable. So we all have to have like our guardrails up of what we're going to treat. I feel pretty comfortable working with anxiety and depression in the perinatal period, but if I have anyone who have symptoms that I'm concerned are bipolar or anything psychosis, I am referring them on immediately, because again, that is to me, potentially an urgent, emergent situation that is going to require more care than I can give. And to know that psychosis and true psychotic symptoms with hallucinations or really strong paranoia. And again, in these settings, the lack of sleep or decreased need for sleep is definitely concerning, because you talk to most perinatal moms, they're exhausted, right? Because they're like, oh my gosh, I'm not getting enough sleep. But if they are still feeling a little bit of hyperactive and they're not getting sleep, that is, again, another flag that we need to be looking out for and referring on for at least a deeper investigation. And just know too that it's really important for us to screen for substance use disorders. Self-medication is very high, and I don't even mean in the field of mental health, just generally in society these days. I work with, I wouldn't say largely, because again, I do a lot with hormones. There is a mental health aspect to that, but these are not necessarily people coming in with predominant mental health issues. But the use of cannabis, of alcohol, is very, very common. And of course, then obviously other drugs too, but cannabis and alcohol, especially the cannabis, is seen as like natural and safe, and it's not going to hurt me or my baby. And that is not correct. There's very strong recommendations from ACOG that preconception, pregnancy, and postpartum, you should not be using cannabis at all. Oops. Oh my gosh. Okay. Sorry, my mouse is so sensitive. Okay, there we go. So this is just a copy of the perinatal mental health tool that we have at PSI. You can get it on the website. We also, there is the Edinburgh perinatal screening as well. And then the MDQ, I have been told in other trainings that can really help in terms of those people. If you are concerned that there might be a bipolar aspect to the symptoms, you can use that to help differentiate. But, like I said, I just have a very low threshold for referral for those things. So again, if it looks the least little bit hypomanic to me, or psychotic, obviously. Luckily, I have not seen that in my practice in this capacity, but that's something that I'm going to be urgently referring on. So here I'd just like to talk a little bit more, and for the rest, we're going to be talking about Arizona specific and PSI in general in terms of the support that we have for families, providers, and then the education and training we do. And I know that y'all are very familiar with and do a lot of advocacy and outreach already. You could follow us if you're interested on Instagram or Facebook for our local chapter for PSI Arizona. Or you could also, or you could follow the PSI National Facebook and Instagram pages as well. But everything I'm going to talk about today is going to be, you can find it all, is even some of the slides on our website or the local. Oh, gosh. Okay. Support for families. Okay. Oh, sorry. So this is just a little bit about our state chapter for Arizona. We're really interested, obviously, in promoting awareness, prevention, and getting the word out about treatment of mental health issues related to childbearing in every county and tribe in the state of Arizona. And we're going to talk about some maps where we really do see that. And I'm so glad there's so many people from Northern Arizona here, because that's where we're really trying to reach out to the communities in that area to get more state coordinators, volunteers, more professionals certified, because we do have perinatal mental health deserts in that area. And we'll see that map in just a bit, but it is something that we are very passionate about here. And I'll be talking again about some Arizona statistics in just a few slides. We do have also a newsletter where you can keep up on all things perinatal in Arizona as well. You can sign up on that through our website. So support for families. Oh. These are literally going to be things that you could just, oh my gosh, I'm sorry. These are going to be things that you can literally just have in your office, or like, yeah, like you can actually contact the national PSI to get posters and things like that if you do work at a mental health clinic or a clinic and where people are going to be going around and seeing this. But we actually just got a national maternal mental health hotline here in the United States in May 2022, so just last year. And you can, write down these. I just listed, again, I'm a private provider, private practice, so I just have it on my website, and just really try to, make sure that all of my patients who are pregnant or postpartum know about this resource. Any pregnant or postpartum patient or their family can call or text English and Spanish 24/7 to get education, support, and referrals. So this is such a useful tool because, again, depending on what service you provide, this, I think it's always kind of a joke. And I would say this is also the thing that happens with medical issues too, is like you wake up at 3 o'clock in the morning and this is what you're thinking about. Well, for your patients or your family or your, clients who may be waking up in the middle of the night, this is a great tool for them. And I think too, especially with a lot of our younger people, although me at, Gen X, I still would prefer to text my whole life rather than make a phone call. So this is really accessible to a lot of people that we'll be working with.
Dr. Lewis, I just put my own question in chat, but how do we get this information? How do we get doctors to be handing this information out to folks?
That is a great question. And here's the thing. I don't know. Yeah, I wish I had a great answer for that, but we are really trying to work. Oh my gosh, I can't get it to stay on that one slide. Sorry. We are really trying to work with OBGYNs, women's health, nurse practitioners. I've done several trainings at Banner for those people. But really, you're right. It is the OBGYNs and even the pediatricians. I think someone did say they work in a pediatric space. And those are the people that are really working with or seeing these patients face to face in kind of that critical time frame, like the first 3 months. But that's where we oftentimes see a lot of these symptoms starting. The other thing is too, is like, again, we don't expect the pediatricians to even like sit for our trainings. We just want them to know that these resources are out there and have a card of ours to just be able to hand out, or have it, the poster hanging in the bathroom so the patient can see it and even self-identify as needing assistance. We're not expecting them, and we hear this from providers all the time. I don't want to do the screening because I don't know what to do if it's a positive screening, which it's like, you know, like that is like a terrible response. Like, it's like, you know, don't ask, don't tell type thing. And I do think that is sometimes, again, they don't mean harm, but if they literally have 15 minutes, and they do have, especially when you look at like, say, access, Medicaid, like these things that they have to check up on. And unless the insurance companies and the state require this, they're not going to do it. Now, the American Academy of Pediatrics did just make a professional recommendation that they should screen all new families, both partners, for PMAD. So that's good. But again, getting that into practice is going to be difficult, I think. But I always feel like it's very frustrating because I literally say, like, all you have to know is these two helplines. And your patient can get all the help that they need, or the PSI website. Like, literally, that's all you need to know. You don't have to do anything unless they're in a crisis, of course. And then obviously you have to act. You can't just say, oh, I didn't know where to send them. So.
Well, and we could perhaps talk offline about this a little bit more too, to see what other states are doing. But, you know, to your point, I know I was screened personally, and once they saw that I screened positively, they had no idea what to do with me. Right. So why even waste my time or their time to screen me? Just give me this phone number and encourage me to call if I'm struggling. But that was, you know, and they knew I was a mental health advocate too. So that was really discouraging, to be screened and then just to be sent home without anything.
And I'll say too, what's really frustrating is that I hear from patients all the time that they'll have that, you know, as a patient, you get put in the room and you're given, or you get the papers, the sheaf of papers you have to go through and fill out. And the screening tools in there, and no one then ever talks to them about it, even if they felt like they filled it out and there were concerning things in there. That is, again, that's not doing a screening, right? So again, very, very frustrating, and I'm not sure I have the answer, but just if you're working within a system, again, you know, hopefully you could get the administration to just buy in, just to have the posters hanging around, because I think it is really, truly, like, say for yourself, if you were in that clinic and went to the bathroom and saw a poster and you were aware enough, you might have like looked on the website to see what was available. We also do have a PSI helpline. This is not a crisis line. The other one is a crisis line. This is, though, you can call or text, and again, it can be the patient or a partner or a family member can call if they're concerned, to get access to the PSI support coordinators. And what they are, they're going to get you to someone in your state. So it's really going to be someone who knows about the local resources. So that can be helpful too. And this is something too, as a provider, you could definitely use, or even like, again, like your sister's struggling and you just want to, because I think the other thing is anyone who struggled with either a physical or a mental health condition, the last thing you want to do is be given, you know, a list of phone numbers for therapists that your insurance takes, and you're supposed to work your way through that and, you know, have people not call you back, or have people who then are not specialists in what you're looking for. So, so this type of a helpline can really help you access the care that PSI offers as well. So I'm just going to go through this brief. How much time do we have? I'm sorry, I think I've gone over, but how much? What is my time where I should be done?
You have about 20 minutes left, Leah.
Oh, good. Okay, we have plenty of time. And for questions. So PSI support coordinators, these are local volunteers who have received extra training. And what we're trying to do is get one of these support coordinators in each of our counties here in Arizona and on the reservations. So right now we have 5, so we do not have enough for sure. And again, if you look on our website, it will tell you the counties that we're still looking for support coordinators in. And these also have, we have support coordinators nationally that work with specific populations. So we have ones that are specially trained for adoptive parents and birth mothers. This is really like, again, you sometimes, I think it's an aha thing when you hear it, but I don't think that oftentimes people think of either the birth mother or an adoptive parent as fitting under the umbrella of a perinatal mood and anxiety disorder. But certainly these people can really struggle. And I think also because they don't necessarily have the typical outcome of a pregnancy, that they might be lost in the cracks too. So if you're working with that population, it's important to help them realize that they might benefit from some of these services. Again, to help them get specific lactation support for the non-birthing partners, LGBTQ, military families, NICU parents, special needs. Like, did we just have a lot of different support coordinators? I oftentimes say this too about our support groups, is I kind of challenge people to come up with a group that you don't find they're a support coordinator for or a support group for, because we really do have a lot. And if you find a patient that is from a population that they can't really find, a specific language group or a cultural group, then, definitely let us know in Arizona and we will work with Central to help you find someone. Oh my gosh, I really want to stop with this next one. Okay, so the support groups. Again, all of this information is on the postpartum.net, which is Central PSI website. You can just go to the support meetings. This is a really great, and again, I think for those patients that you might have, hopefully they have the internet capacity, but for all over the state and really all over the country, you can access these free virtual support groups. It's 90 minutes, 30 minutes of education with 60 minutes of talk time by specially trained therapists. I've had patients and partners, because there are also partner groups, and even grandparent groups too. Like if they're very active in taking care of the family, there are support groups for them too. But they can just sit and listen. They don't have to participate. It can be anonymous. So this is something that is very accessible for people, again, with the caveat of having, an internet connection. And again, just to point out some of the groups that you might not be thinking we would have a group for, but again, infertility is under that perinatal umbrella. So we have a group for that. There's also post-abortion support groups. Terminate, again, there are these little specific pockets where, a late term miscarriage or an abortion, after a certain date because of medical reasons, it's a very different group than, say, the general PMADs or general pregnancy termination group. So we do have those real specific ones as well. And then again, like the support for the families after a maternal death or a fetal death or those touched by psychosis, that can be very traumatic for more than just that immediate family too. If there were other family members or friends who were involved or witnessed, that can be very difficult. I think I missed the slide here, sorry. Oh, I wish my arrows worked. For some reason, I can't get that to work. Okay, here we go. So we also have a peer support mentor program as well. So these are all people who've struggled with PMADs, both male and female, birthing partners, non-birthing partners, and then they've decided to go on and get specially trained and can provide peer support to people who are struggling. It's weekly communication. It can be done by email, text, phone, whatever your patient or client is preferring, and it goes for 6 months. And quite honestly, I work with some people who do this as a volunteer for PSI, and they oftentimes stay in contact, way past that 6-month mark with some of their peers. So this can be really helpful, because I think the one thing that we really want to reinforce to a lot of people that we work with in this space is with support, they will get better. And so we do want to be able to really get that message. And oftentimes working with a peer who has been there and has recovered can be so powerful. So support for providers. Oops. So I'm going to go through some of this, if I can get to it a little more quickly, just because, again, it's all on the website. We have, oh my gosh, I'm sorry. I'm going to stop with this one. So we do on the PSI website, we have a psychiatric referral or a consult line. So if you are a psychiatric prescriber or you work with them and you have it doesn't have to be someone who is specially trained in PMADS. Actually, this is for people who aren't specially trained in prescribing for the perinatal population. There is a new kind of specialty. I don't know how much you have heard about it or know and have access to these providers, but there are reproductive psychiatrists now. And these are psychiatrists who are specially trained to care for, again, perimenstrual dysphoric disorder, perinatal mood and anxiety disorders. And these people are so helpful in helping even psychiatric prescribers who in any other situation could have a lot of confidence about their prescribing abilities, might really struggle in this space in keeping up on the research on what is the best treatment in the perinatal population. So, so PSI has one, and then we just got one thanks to U of A. It is accessible to anyone in the state of Arizona who is a prescriber, and they can just call the phone number here. It just started June 1st. So this is brand new, and it's available from 12:30 to 4:30, Monday through Friday. And again, like I said, this is for prescribers to call and to get advice. But again, if you're and you might be the person, even if you're the therapist with this patient, you might, or even hopefully even a family member, you might be the person letting the patient know that their doctor, especially in those rural areas where they're not going to have the availability to see a reproductive psychiatrist or maybe even a psychiatrist, that their OB provider or PCP can call and speak with a reproductive psychiatrist and get advice on how to prescribe to their patient. So that is very exciting here in Arizona. We also have a PSI perinatal mental health directory. The one good thing that's happened with COVID is so many people are doing things online. I mean, even like the ability to do this kind of a presentation to people all over the state is exciting, but we have so many therapists and psychiatric prescribers that have had training in perinatal mood and anxiety disorders or actually have the extra certification. They can list their practice on this PSI directory for free, and people can find them, or you, as someone who is helping someone find care, can help them here too. It's a zip code search, very easy. And like I said, we really are being able to provide access, again, with the idea of phone or internet service to anyone in the state with all the people who are doing telemedicine these days. So that's very exciting. But this is, again, another thing that OBGYNs, PCPs, pediatricians can have on hand to give their patient, because again, instead of going through this just like a list on Psychology Today, they're going to be able to find people who've actually had extra training in PMADS. We also have a Perinatal Mental Health Alliance for People of Color. This is a program within PSI for providers of color who provide care to specifically communities of color. So that's another cool program that people can get involved with if they're, again, identify as a person of color. We actually just had the first in the nation and also obviously in the state, PSI training, both the 2-day training and the advanced psychotherapy training for and by providers of color in May here in Phoenix, which is pretty exciting as well. We were able to give a lot of scholarship money to that. So the education and training, I'm going to go through this really quick too, just because I know not everyone is going to necessarily go through this as part of their, what their practice is or their profession. But there are a number of certificate trainings out there that, again, this is great, just basics, like, expanding on some of the things we've touched on here today, is there's a maternal mental health 2020 moms does an online certificate course. And then there is a 2-day certificate training for perinatal moon anxiety disorders called the Components of Care through PSI. And then PSI also offers advanced psychotherapy, which would be the second step if you were interested in taking that further, and advanced psychopharmacology for prescribers. At that point, and this kind of just breaks down like the targeted audience for each of the trainings. Here in Arizona, especially around our scholarships that we're giving, we do have scholarships, although right now we're in a little bit of a lull because we just gave out like kind of amazingly $40,000 in scholarships for all these trainings, and then also to be able to take the certification exam. But we have another influx coming in, so hopefully we'll be able to give that out too. But you can do it as an affiliated professional, or just, again, anyone who works in the space of social work or community mental health, and you just want to get some more education in this specialty. You can do the 2-day Components of Care or the PSI 2020 Mom Maternal Mental Health course. And then for those who are advanced in terms of therapists, psychotherapists, social workers, and counselors, they could do the advanced psychotherapy. And then for prescribers, the advanced psychopharmacology. And then you can sit for the certification exam if you're interested. And why this becomes an issue, especially here in Arizona, is, Access just came out with, and we have links to this on our website here in PSI Arizona, for the perinatal mental health, maternal mental health, advisory committee report of recommendations. Their final recommendation that Access came out with in January was to increase the PSI certified perinatal providers training here in Arizona. And we're really excited about this because we just started with a PSI board here in Arizona in 2016. And then during COVID, there was some, growing pains and some restructuring. And since then, so we ended 2021 with 30 PMHCs, which is the certified perinatal mental health provider. We're just about at 100 now. So we really have had a push with, this is kind of one of the main things we work on, is to get most people certified as possible, because the other thing is Access in the state are working on getting a subspecialty designation for PMHCs. Just like there is, you probably are all familiar with like substance use disorder subspecialty. So this will be a subspecialty with Access, and we're really pushing for Access to also have this mean something to therapists, that they will actually get reimbursed at a higher rate than someone who does not have the PMHC. So we can really, again, try to encourage more people to get the extra training.
Leah, this is Lori. I see community health workers mentioned on that slide with Access. Are you working to partner with the community health workers?
We are, and I can't speak to a ton of this because Elizabeth Wood, who is my co-chair, she does a lot in other forms of outreach, but we certainly are. We've talked to Access in terms of their community health worker programs that go out into people's homes. We're doing education with them.
Leah, you just muted.
That was me. I did it by mistake. Can you help me there? I'm sorry. I meant to mute myself and I had my arrow on Leah instead. I apologize.
Stop muting me. No, I'm just kidding. So I can get you that information about who specifically we've been working with, but I would just like to say that just you having this information, if there are any groups that you would like us to present to, this is basically the presentation we would do, let us know, or let that have that group reach out to us. We're always happy to do the education around this, to let people know that this is kind of coming down the pipe in terms of providing care. But this is, it's nice because, again, these recommendations, I think you know how slow things work with access and with the government. So who knows when this is all going to be happening, but they have outlined these important steps here in Arizona to improve the maternal mental health here. I'm sorry, that probably wasn't a very good answer.
No, it was, and the reason I brought up the CHWs is because they're already working. It doesn't matter what socioeconomic class you're in.
Yes.
This hits everybody, but that particular group is already in the rural communities working with the people that are having these that are having children in that. And I could see that they, you know, that they could really, everyone could benefit, but here's a population, a provider that's already targeting and working with the population that might give you easy access for your information to reach.
Yes, that is true. And we have done, I see a little bit more clearly about what you're asking. And we have done, like, the rural county health departments had reached out, and we've done trainings for their staff, like in Graham County. We also have a gal in Yuma who's a therapist, who's a PMHC, and is working and presenting a lot of trainings to the community health workers in Yuma. So we're just trying to really expand our goal. Like, even if we can do like these virtual trainings, which again, we're happy to do anytime, but our goal is to really have the state coordinators and trainers all around the community too. So, because they're the ones who are going to find out those people who are doing those things and be able to bridge that gap, and then offer to give the presentation right at the community, you know, at the center of employment too, to reach out.
So I'm glad to hear you say that you're working with the county health departments. And I know, like Northern Arizona, we have so many rural communities, and the community behavioral health clinics provide youth services. You've got Trish Reiner from Family Involvement Center here on the call today. And this is the first time I've heard of, you know, what you're doing and who you are. And I think just, you know, getting the word out is important, and how to do that and who to reach.
Yeah, and like I said, if there's anyone that you think might be interested, you certainly just, you know, send them our information and have them reach out to me directly, to Elizabeth directly. I'm the head of the education committee, so we will get someone to train, you know, their group. So that's not a problem. But that is part of the problem, is getting the word out. I mean, we try to do things, but I think it's kind of like the same thing that was brought up about getting the word out there, just about, you know, screening and PMADs, and how, you know, how much of a kind of like two-pronged. We have to get the word out to the public. We have to get the word out to the community workers too, and the providers.
Well, and the people that need the services, the people that need to call the helpline, to call, oh, you have peer support. We're all about peer support.
Yes, definitely. So here's just this is a report card that was just put out. It used to be called the maternal, oh wait, I'm sorry. I forgot. It's on our website, so you can look at the exact report if you're interested. But what this is showing here is where the highest needs for perinatal families are. And you can see that in the very dark purple are the communities with the highest needs. And then the circles show, and if we just look at Arizona here, we can see our high needs again in the northern, kind of like all around Maricopa County and Pima County, if you can envision that. Are big areas where we have a very great need and very few providers. So again, that is definitely the communities we're trying to reach out to. So again, just looking at that.
In our chat, Trish has said that she would love to have you present at one of their staffings. She's going to connect with her clinical director on this, so you'll be hearing from Family Involvement.
Oh, thank you. Thank you so much, Trish. That's great. You can definitely email me directly too. I'm always happy to help work that out. But here it is, the Policy Center for Maternal Mental Health. And interestingly, even though things look so bleak in Arizona, we are one of the top performing states for providing maternal mental health care. So California was best, but even for them, they were at a B-. We are at a C in terms of providing care to maternal mental or for maternal mental health issues here in Arizona. So it just shows that, you know, while we may be a top performing state, you know, the bar is not very high, unfortunately, because the other states are just really lagging as well. So again, the states meeting the provider patient ratios is just not happening. And what we did here in the statistic here in red, we figured out that each Arizona prescriber would have to have, I don't think that's prescriber. I didn't make the slide, I'm sorry, but I think that is actually a therapist, a psychotherapist. Each Arizona psychotherapist would have to have 750 active perinatal patients for every perinatal mom who is in need of care. Now, I don't know about you, but the idea of having 750 active patients that probably should be seen at least for some amount of time weekly or bi-weekly, that's insane. We obviously are not providing care to everyone who needs perinatal services. And that's really just looking at the births as in the birthing person. That's not including the non-birthing partners as well. Okay, so, and then here's the state of the state. So again, this is just kind of zooming in a little bit more. We have, obviously, our whole state is a perinatal mental health desert, no pun intended, but of our 8 Arizona counties, we still have no perinatal mental health certified providers in that county. And so again, you know, the telemedicine expansion has really been helping. But I think I'm not sure if that, I think that might have been Lori who was speaking before, but what I think your statement really speaks to here is that people don't even know that there's a desert and that there is this opportunity to really have these type of providers in their county. So again, if we can help to get the word out that there are these providers out there, and just looking at the provider directory can get you or your client hooked up with this service, then that's going to go a long way in terms of helping these people find the care that they need. Of course, on the other side, we do have to expand the coverage to the providers and make it more, I mean, because again, I know I'm not telling you guys anything you don't know, but there's certainly a lot of providers then who don't take access. So that's a huge issue. We have to get the reimbursement up and expanded to really, I think the other thing that we really are trying to work with access to is oftentimes they say their panel is closed in a certain region. Well, how can it be closed in a certain region when you're not even specifying who the perinatal providers are? You're just saying you have a provider there. But if they're not a specialist in perinatal mood disorders, then your customer, your insuree is not going to, the insured person is not going to get the care that they truly need. So we're trying to really make that clear to access that it is something different. It is, it's going to help them in the long run if they can take care of these patients and families before the time of crisis. So I just wanted to point out too, there are some other, and I say reproductive psychiatry, but I would also just say reproductive psychotherapy resources. Again, just a reminder that PSI Arizona and PSI Central, we each have our own website. Sometimes PSI Central, if you ask me, is a little confusing about some things. So if you start at PSI Arizona, we've kind of tried to segment out things. So if you're looking for a 2-day training that's happening online, you can find it on the Arizona and click the link and it'll take you to how to register on PSI Central. We're trying to make our website a little more user-friendly. There's also the Massachusetts General or Mass General Hospital Center for Women's Mental Health. This is an excellent resource. If you provide, again, trying to break down that bifurcation between mental and physical health, this is an excellent resource if you are in any way caring for women. They put out an excellent newsletter that will break down new research in the field, in the areas of infertility, pregnancy, postpartum, menopause. And so you can really keep up on the new research and where that intersection is between women's health and mental health. They also have a lot of good prescriber and provider trainings if you're looking for even more education. Again, the PSI, that's a 2-day training. You could do, and I know that there's a lot of people who want like more information on specifically CBT. They have some really good CBT and DBT provider trainings there as well. There's virtual rounds, which is really good if you do this. Again, your specialty. One of the other good things that came out from COVID, they started doing their rounds online. So you can, and again, you don't have to participate, you can just listen in, but you can find all that information on their website. There's also some really handy books that I found that can just talk and help you like explain to patients of, just because especially in our, I didn't really talk about this phenomenon, but it does seem to be in the Western culture, we have more issues with perinatal mood and anxiety disorder because we do not give families the protective kind of idea of the rest and nest or I'm going to pronounce it wrong, but quarantine. It's kind of like the quarantine, but in Spanish. But this idea of like a 3-month period where your job is to take care of yourself, take care of your baby. Not doing work, not cleaning your house, not cooking, not, caring for all the kids. Because in other cultures, they have it baked in where you're going to have your extended family and people from your community helping you. In our culture, we don't have those supports. So sometimes because I do feel, and again, if you work with this population, or if you've experienced it yourself, you might have felt like you were totally alone and that you're the only one feeling like this, because everyone on Instagram is back to their beach body and like making all this homemade food for their baby and like, will have a perfectly clean house when that is not the reality. And so sometimes we do have to just, allow people to have the space to admit that they're struggling and get the help. So those resources can be helpful. We have a really great local community resource called Matrescence. It is a very low cost, but kind of a very good online provided postpartum prep. A lot of times people think they're going to bring their baby home and that's it. They just like, everything's going to be peachy, no problems. But this class, which is they meet 4 times over the course of 8 weeks, and it includes the partner as well. Patients can kind of learn the realities and what to look for in terms of bringing a baby home and where they might have issues. And it really does bring up the fact that like, hey, if you've had issues with anxiety and depression in the past, you are going to be at higher risk. If you're struggling with a loss of a job or something like that, like just kind of really educating the patients on what to look out for, like the OBGYNs do in terms of bleeding, in terms of cramping, in terms of breastfeeding. They don't get to be, people never hear about this, like in terms of their preparation for taking a baby home. And then again,
Sorry, Dr. Lewis. I see
okay.
we only have 2 minutes left
Yeah.
and we have a couple quick announcements. So I just need to stop you there and thank you so much for bringing this information to our attention. I know you shared with anyone that you're willing to do these presentations elsewhere so folks can contact you.
Definitely.
If you're willing to share your slides, we can share them with the group. And, as far as, the work that you're doing with Access, incredible. Let us know how we can help you. And I'll obviously connect, I've been in contact with Elizabeth, but we are really, really willing and happy to connect you. This is something that's near and dear to my heart. As you know, I know it would have saved the system a lot of money and saved my son from a lot of his own mental health issues had I got the help that I needed very, very early on in my pregnancy. So thank you for bringing this to our attention. And with that said, then Lori, I'm going to turn it over to you for some quick updates.
there. Thank you, Leah, so much for your presentation. And thank you everyone who has participated in being here today. Our next Mental Health Monday, I put the announcements in the chat if you want to copy and paste them for future reference, but we have our next Mental Health Monday, July 31st on the legislative process. The next NAPFC meeting is on Wednesday, July 19th at 1. We meet the third Wednesday of every month. Visit namiyavapai.org for future NAMI Yavapai events and the local Zoom times and links. And here's the email for more information on NAPFC and meeting times. If you have any questions about NAPFC, you can contact me. Again, thank you all for being here.
Thank you.
That was great, you guys. Thank you so much.
Very nice.
Thanks, Julie.
Thank you so much. It was very insightful.